Thank you, Mr. Thank you, Mr. Chairman, ladies and gentlemen. I have no disclosures for this talk. Cardiac risk factors are associated with increased incidence of atrial fibrillation. Indeed, with each additional cardiac risk factor, this risk of atrial fibrillation increases proportionately, reaching exponential levels. Shown in this slide is the increased risk of AF with each component of the metabolic syndrome, with an overall 67% increase in risk of atrial fibrillation. Pericardial fat has emerged as an important driver of the substrate of AF in obesity. Indeed, data demonstrates that it is not only predictive of association of AF, but also there is a clear dose-dependent relationship with the severity of atrial fibrillation. Furthermore, pericardial fat we have shown in this study is predictive of ablation outcomes. However, the mechanistic link between the epicardial fat and atrial fibrillation is not well understood. This study demonstrates the paracrine role of the epicardial fat. Here, the murine cardiac tissue was incubated with a supernatant of epicardial fat harvested during the cardiac surgery. Shown here is the petroserous stained cardiac tissue. The fibrous tissue is shown in red here. As compared to the control, the tissue incubated in the epicardial fat of the superman demonstrates enhanced fibrosis. We have also recently demonstrated a new substrate in obesity in an ovine model. These are the voltage maps of the left atria, of the control and the obese shapes. As compared to the control, there are increased fractionation as depicted by the pink dots we can see on the obese animals. The histological examination of the posterior left atria shows a pristine demarcation between the epicardial fat, as we can see here, and the myocardium. In comparison, the fat cell from the epicardial tissue here infiltrates into myocardium, leading to conduction clot, islets of these fibrosis and the cells, all creating substrate for atrial fibrillation promotion. We have recently presented legacy study that the risk factor weight and risk factor management leads to a dose-dependent reduction in AF burden and improved maintenance of sinus rhythm. However, the mechanism by which weight loss leads to a reduction in AF burden is unclear. We therefore hypothesize that weight and risk factor management to treat the primary cause of atrial fibrillation results in beneficial structural remodeling and reduction in pericardial fat volume. In this study, of the 112 consecutive patients referred for ablation due to symptomatic atrial fibrillation, 67 patients had PMR greater than or equal to 27. We excluded patients who had previous ablation, had permanent atrial fibrillation, has been on the neuron in last 6 months, or if they had any of these serious medical conditions. Patients were then randomized in 1-to-1 fashion into control group or to risk factor management group. Both the groups underwent baseline investigations, including echocardiography, cardiac MRI, and blood tests. In addition, risk factor management group patients underwent dedicated risk factor management in a physician-led clinic. After a mean follow-up of 12 months, these investigations were repeated. Risk factor management was in keeping with AHA-ACC guidelines. This included weight management, where a structured program was delivered through a dedicated clinic. Meal plans were given with the initial target of 10% weight loss. Patients were advised to maintain a lifestyle journal. Dyslipidemia and glucose intolerance were tested at baseline, and if found to range were managed with lifestyle modification. However, at 3 months, if there was still to range, pharmacotherapy was prescribed. Everyone maintained a blood pressure diet. Lifestyle modification with salt restriction and pharmacotherapy was utilized to keep the blood pressure less than 130/80, at least 80% of the time. Everyone underwent formal sleep study, and if AHI score was more than 30, CPAP was used. Smoking cessation and alcohol reduction to less than 30 grams per week was the target. This slide shows the baseline characteristics of the two groups. The groups are color-coded, with gray being control group and orange being risk factor management group. The same color scheme has been maintained throughout the presentation. As we can see, there is no significant difference in age, type of atrial fibrillation, or any of the identified cardiac risk factors. The following slide shows the results of our study. As I said, the grays are control and orange being risk factor management group. The bar charts compare the two groups at baseline and at final follow-up. Both the groups demonstrated some improvement in risk factor management. However, this was significantly greater in those who underwent physician-led goal-directed risk factor management, which was associated with significant weight loss and a better glycemic control. With weight loss, the number of patients with severe sleep apnea were also reduced in risk factor management group. Risk factor management group also had a significantly better or improved blood pressure control. This slide shows the impact of risk factor management on cardiac adiposity. We used cardiac MRI scan to look at periatrial and periventricular fat. At baseline, both the groups had similar periatrial fat. Risk factor management was associated with significant reduction in both periatrial and periventricular fat tissue. This slide shows the impact of risk factor management on left atrial volume. Again, both the groups had similar left atrial volume at baseline. Risk factor management was associated with significant reduction in left atrial volume at final follow-up. We further wanted to look using cardiac MRI scans, specifically looking at end systolic and end diastolic volume. At baseline, both the groups had similar end systolic volume. Risk factor management was associated with significant reduction of both systolic and diastolic volume. This was associated with an improvement in left atrial ejection fraction. This slide shows the impact of risk factor management on left ventricular dimensions. As we can see, both the groups had similar left ventricular and diastolic diameter at baseline. At final follow-up, we saw a significant reduction in left ventricular and diastolic diameter. This was associated with a significant improvement in left ventricular diastolic function. This slide shows the effect of risk factor management on ventricular structure. We see at baseline both the groups had high septal thickness. Risk factor management led to a beneficial structural remodeling, and we saw a regression of ventricular septal thickness. When we looked at cardiac MRI, there was reduction in left ventricular mass index. We finally did serology in looking for fibrosis markers. Again, while they were similar at baseline, risk factor management was associated with a significant reduction in fibrosis markers such as MMP9 levels and TGF-beta levels. In conclusion, Mr. Chairman, ladies and gentlemen, risk factor management leads to a marked reduction in pericardial fat volume. We see a reduction in left atrial volume, left ventricular mass, and improvement in fibrosis markers. These findings highlight the pivotal role of risk factor management in overall management of atrial fibrillation, particularly in the strategy of rhythm control. Thank you for your attention.
Thanks. This talk's open for questions now. That's a very nice study, and I imagine not an easy lot of work involved in doing it. Can you comment on rhythm and what happened to their heart rate and rhythm? Were these patients all in atrial fibrillation?
Absolutely.
Throughout the study?
So these patients were referred for ablation. They, as per the guidelines, they are only referred once they are resistant, symptomatic atrial fibrillation, resistant to one antiarrhythmic drugs. Then only they get referred, and they have high symptom burden, severity of atrial fibrillation before they come to a cardiac electrophysiologist for an option for ablation. At that stage, we take them. Some patients went aggressive risk factor management, others for control, and we have looked at the impact of these.
So this is prior to ablation?
Absolutely.
And so were these all sustained atrial fibrillation or paroxysmal?
As I have shown in the baseline characteristics, 46% of the patients were paroxysmal, and about 54, some around that, are persistent atrial fibrillation. So it's a mixture of paroxysmal and persistent.
And did the groups differ in the number of paroxysms or?
I've not shown in this study, but I have my ARS cohort study, which was published in JACC in December, I did a separate analysis. That was an outcome analysis I've seen. Of course, paroxysmal, because of the nature of having less substrate, less progressive disease, had a better outcome than persistent.
Hi, Jamie Rankin from Perth. Thanks for the talk. I think this intervention led to significant weight loss, and clearly all the other factors you've shown are very impressive. But what is it about your program that was so successful? Many of us in clinical practice have struggled getting any sort of success in this type of population. What was different about your intervention that led to the success?
So this has been a question came to when I was presenting my late-breaking trial in SSC as well. So number one important point is these are AF patients. They come to a cardiac electrophysiologist when they're highly symptomatic. They do whatever you tell them. That's number one. Number two, the program is very intense. These patients, I personally see them every 6 weeks. Every week we have an email contact. They are sending their weight and blood pressure. Just that accountability they have. In the clinic, we sit with them, we discuss a personalized, tailor-made program for that individual patient is given. I think that really helps. Rather than just being a general program, hand it over, go away and do that, a tailor-made program for that patient who becomes in charge of his own care, becomes uncomfortable because he has to come and report, is additional factor which has helped us to get the success.
Do you know if they keep the weight off after they exit the study?
So my long-term study, which was published a month ago in Journal of American College, looked at the effect of patients who attended risk factor management clinic versus not, and looked at the effect at 5 years. The patients who attended clinic, 84% of those patients not only maintained the weight loss, but has less weight fluctuation, which is a bigger problem in patients when they lose weight. If they attended clinic initially and they lost to follow-up, they generally either have mild fluctuation or they regain the weight back again. So at least 6 monthly, that contact where they are accountable, or at least that short discussion with them helps to keep the weight off.
Right.